COVID-19 outbreak. Cardiopulmonary resuscitation management. CPR. Contents. Introduction. Definitions. General goals for resuscitation in suspected and confirmed COVID-19 patients. Resuscitation of confirmed or suspected COVID-19 patients. Rapid sequence intubation steps. American Heart Association COVID-19 update. General airway management. Transport considerations. Introduction. COVID-19 is highly transmissible, particularly during resuscitation. Rescuers must continuously balance the immediate needs of the victims with their own safety. The evolving and expanding outbreak of COVID-19 has created important challenges to resuscitation efforts and requires potential modification of established processes and practices. Intubation is the highest risk procedure for droplet dispersion in patients with COVID-19. The aim is to get the best possible chance of survival without compromising the safety of rescuers. Definitions. Aerosolization. Mechanisms that produce aerosolized virus, smaller particles that float in the air far longer than droplets, and that can also travel farther like coughs and sneezes. HEPA filter. HEPA stands for High Efficiency Particulate Air. Supraglottic airway. Devices that keep the upper airway clear for unobstructed ventilation, like the laryngeal mask airway. Capnography. The monitoring of the concentration or partial pressure of carbon dioxide in the respiratory gases. Advanced cardiac arrest algorithm. Like Advanced Cardiac Life Support (ACLS) for adults and Pediatric Advanced Life Support (PALS) course. RSI Rapid Sequence Intubation. NMBA Neuromuscular Blocking Agent Paralytic Medication. IVF Intravenous Fluid. PPE Personal Protective Equipment. General goals for resuscitation in suspected and confirmed COVID-19 patients. Improve CPR outcomes. Reduce provider exposure to COVID-19. Staff safety remain a critical priority. Promote strategies with lower aerosolization risk to prevent contamination and spread of virus. Maximize first attempt success intubation of confirmed or suspected COVID-19 patients, while keeping patients and providers safe. Resuscitation of confirmed or suspected COVID-19 patients. CPR box. Each floor or station should prepare a box that contains the following items along with a standard crash card ready for CPR team members. 6 plastic bags, each one contains below items. Full body gown. N95 masks. Eye goggles. Head shield or face mask with shield. HEPA filter, if available. Shoes cover. Double gloves. Reduce provider exposure to COVID-19. Before entering the scene, all rescuers should don PPE to guard against contact with both airborne and droplet particles. Clearly, communicate COVID-19 status to any new providers before their arrival on the scene. Limit intubation and resuscitation team in room to 5 members. First responder nurse should initiate BLS while other members arriving. Second responder nurse, who will bring the CPR cart and connect monitor and other devices. Critical care nurse, for medication administration and management of defibrillator. Physician team leader, respiratory therapist. Other staff should be waiting outside. Anesthesiologist, waiting to perform intubation if needed. Recorder, receiving messages verbally. Nurse managers and charge nurse on each floor should work to prevent crowds and unnecessary people entering the rooms while CPR is being processed. This is an illustration for suggested room organization. Lower aerosolization risk. Clear role assignment with airway, breathing, and preparation for intubation. Consider early intubation for indicated patients in order to minimize aerosol spread. Wearing goggle cover by the person who is performing the intubation. Avoid excessive ventilation prior to considering intubation and apply 1 second to each breath. Apply filter to resuscitation bag. Stop chest compressions during performing intubation. Make sure to inflate endotracheal tube cuff prior to resuming chest compressions. Apply capnography as a tool for confirming proper intubation in order to minimize contact with aerosol. Minimize the likelihood of failed intubation attempts by assign intubation to expert provider with the best chance to success from the first attempt. Pause chest compression during intubation. If available, video laryngoscopy may reduce exposure to aerosolized particles and should be considered. If intubation is delayed, consider manual ventilation with a supraglottic airway or bag mask device with a HEPA filter. After intubation, maintain closed circuit and minimize disconnections to reduce aerosolization. Promote strategies with lower aerosolization risk. If available, attach a HEPA filter securely to manual or mechanical ventilation device before administering any breaths. Patients in cardiac arrest should be intubated with a cuffed tube at the earliest feasible opportunity. Avoid manual bagging ventilation unless life-threatening refractory hypoxemia. Avoid excessive ventilation, 1 second per breath. A vice grip VE is recommended to maximize the face mask seal and minimize gas leak after induction. Rapid sequence intubation steps, the 7 Ps. Preparation, pre-oxygenation, pre-intubation optimization, protection of patient and staff, paralysis with induction, placement, intubation, post-intubation management. Call for intubation. Why intubation is called or considered. Cardiopulmonary arrest, lost airway or jeopardized airway, respiratory distress, respiratory rate greater than 30 breaths per minute, hypoxemia, SpO2 less than 93% on room air, PaO2 FiO2 ratio less than 300 mm Hg. Preparation. Team should have a discussed plan, all no part, closed loop communication at all times. Avoid awake intubation. Cough during awake intubation increases viral spread. Be safe, accurate and swift. Aim to succeed at the first attempt because multiple attempts increase risk to sick patients and staff. Do not rush but make each attempt the best it can be. Prepare all required equipment and draw up and label all medications before entering intubation room. Keep all non-essential equipment just outside room. Use negative pressure room for intubation whenever possible. If not available, use a neutral pressure with the door closed. Ventilator and resuscitation bag should be ready with filter. There is no emergency intubation. All PPE must be done appropriately all times. Pre-oxygenation. Pre-oxygenate patient for 3 to 5 minutes with 100% O2 using low 10 to 15 liter per minute and non-rebreather mask. Avoid breathing manual ventilation, if at all possible. 5 minutes of pre-oxygenation preferred if circumstances permit. If needed, pre-oxygenate with modified, non-invasive ventilation by using tightly fitting, non-vented mask connected to closed-circuit, dual-limb ventilator with HEPA filter. Use a full face mask if available. Reduces aerosolization. Mask must fit standard ventilator tubing. Continue non-invasive ventilation until patient apneic. Suspend ventilator before removing mask for intubation. Upright posture or reversed Rendenberg positioning improves pre-oxygenation. Consider passive supplemental oxygen with nasal cannula during intubation attempts, 6 liters per minute. Do not use high-flow nasal cannula due to exposure risk. Pre-intubation optimization. May give IV fluid bolus prior to giving rapid sequence intubation medications to patients who are volume depleted. Avoid high-volume fluid resuscitation in COVID-19 patients at risk for acute respiratory distress syndrome. Push-dose pressor may be needed for patients at high risk for hemodynamic decompensation. Vasopressor infusion, for example, norepinephrine, may be needed for patients with hypotension or hemodynamic instability before or following administration of RSI medications. Protection of patient and staff. The appropriate use of PPE, standard and droplet precaution must be implemented all the time. PPE should be worn and checked before all airway management, even in an emergency. Wearing goggles by the person who is performing the intubation. Clearly communicate COVID-19 status to any new providers before their arrival on the scene. Limit personnel in the room to only those essential for patient care. Avoid listening or feeling for breathing by placing your ear and cheek close to the patient's mouth. Paralysis with induction. Use high-dose neuromuscular blocking agent, paralytic medication, rocuronium 1.5 mg per kg IV or succinylcholine 2 mg per kg IV. Goal is rapid onset apnea and elimination of cough. Placement, intubation. Have available all standard airway equipment plus bag mask with HEPA filter. Place the filter between the resuscitation bag stem and the mask. Video laryngoscope. Ventilator and tubing with inline adapters for suctioning and bronchoscopy, and HEPA filters. Waveform capnography, if available, should be placed between the filter and the resuscitation bag stem. Supraglottic airway device as backup. Do not delay intubation if the patient is worsening or is unstable. Proactive intubation is preferred, especially with increased inspiratory efforts. If trialing high-flow nasal cannula or BiPAP and CPAP, if no improvement within 1 to 2 hours, distress, PaO2 FiO2 ratio is less than 150, intubation is recommended. Consider use of a covering over patient's head during intubation, large clear trash bag, O2 tent, etc. to decrease aerosolization risks. Use video laryngoscopy whenever possible, if available. Supraglottic airway preferred for rescue oxygenation and ventilation if needed, for example, intubation difficulty. Ensure endotracheal tube is inserted 19 to 22 cm measured at teeth. May reduce need for confirmation by chest radiograph. Assign intubation to expert provider with the best chance to success from the first attempt. Stop chest compressions during performing intubation. Defibrillation. Hand-off defibrillation, that's mean using the pads for shockable rhythm instead of paddles. Make sure to inflate endotracheal tube cuff prior to resuming chest compression. Apply capnography as a tool for confirming proper intubation in order to minimize contact with aerosol. If intubation is delayed, consider manual ventilation with a supraglottic airway or bag mask device with a HEPA filter. After intubation, maintain closed circuit and minimize disconnections to reduce aerosolization. Don't routinely use Crickert force. Post-intubation management. Inflate cuff immediately following endotracheal tube placement and prior to initiating PPV. Confirm placement of the endotracheal tube. If a colorimeter or other removable EtCO2 detector is used, clamp the endotracheal tube before removing the device. After confirming endotracheal tube placement, clamp the endotracheal tube, connect the ventilator tubing, and then remove the clamp. HEPA filter between endotracheal tube and ventilator should be in place. Start mechanical ventilation. Secure the endotracheal tube. Ventilator settings suitable for patient with ARDS are likely to be needed, assuming COVID-19 related respiratory illness is reason for intubation. Procedure bundles can reduce exposure. May choose to perform intubation and central venous catheter placement together and then obtain portable chest radiograph to assess both. Limit ventilator disconnections. When disconnection required, clamp endotracheal tube first and disconnect at end expiration. Ideally, use intratracheal tube and ventilator with inline adapters for suctioning and bronchoscopy. Ensure cuff pressures between 25 and 30 cm H2O ensures appropriate seal with airway. No evidence for overinflating cuff. Ensure adequate sedation for patient care and safety and to avoid accidental extubation or disconnection of tubing. Bag, transport, and clean all equipment as required. American Heart Association COVID-19 update. BLS healthcare provider. Before attempting CPR. Done PPE. Limit personnel. During CPR. Provide rescue breathing using bag mask device with filter and tight seal. Consider mechanical compression device. Advanced cardiac arrest algorithm. Before attempting CPR, same as in BLS. During CPR, as in BLS. Give oxygen. Limit aerosolization. Prepare to intubate as soon as possible. Pause chest compressions for intubation. If intubation delayed, consider supraglottic airway or bag mask device with filter and tight seal. Connect to ventilator with filter when possible. Advanced airway. Minimize closed circuit disconnection. Use intubator with highest likelihood of first pass success. Consider video laryngoscopy. General airway management. High flow nasal cannula. Consider lower rates of flow, 15 to 30 liter per minute versus 30 to 60 liter per minute. Should still equal minute ventilation. Consider surgical mask on patient over patient interface. Strongly consider negative pressure room or closed door minimally and airborne precautions. Stop flow before removing device. Non-invasive ventilation. Use a dual lamp circuit if possible. Filters placed at equipment outlets. If single lamp circuit, consider HME between exhalation port and mask. If possible, avoid using a mask with an exhalation port. Single lamp use circuit with a leak port. Filter it, dual lamp, filter expiratory side. Use a higher EPAP if tolerated. Much above 12 is difficult, but do not exceed 20 cm H2O due to high risk of gastric insufflation. Maintain delta pressure, IPAP, EPAP, for tidal volume around 6 ml per kg. Stop flow before removing device. Suctioning and bronchial hygiene. Strong preference for closed suctioning only inline suction when intubated. Minimizes aerosolization exposure. Decreases recruitment of lungs, alveoli collapse. Do not induce for sputum collection, such as use of hypertonic. Avoid open suction techniques, including nasotracheal suctioning, open suction of the tracheostomy, stoma. Avoid bronchial hygiene therapies that may increase risk of cough when possible, chest physiotherapy, IPV, etc. Exception: diseases that produce abnormal secretions such as cystic fibrosis, bronchiectasis, etc. Bronchoscopy. High risk due to potential exposures. Priority use of PPE, N95, face shield, gown, gloves. Avoid use if possible. Unplanned extubation. Not an emergency. Must take the time to put airborne and contact PPE on correctly. Turn off ventilator as soon as safely possible. Place on non-rebreather mask if not using manual resuscitation in hospital. If using, consider two-handed technique with bagging to avoid exposure. Assess patient for need for re-intubation. Post-mortem extubation. If patient dies prior to extubation, airborne and contact precautions still necessary. Ensure ventilator is off before disconnecting. Some recommend turn off ventilator. Clamp endotracheal tube. Disconnect the ventilator and immediately cap it. Leave patient intubated. Leave clamped or consider immediately placing filter and cap on end of endotracheal tube. If possible, avoid procedures that increase exposure risk, including trach placement or change, bronchoscopies, etc. Transport considerations. Avoid transport when possible, including limiting away from room imaging and procedures to absolutely essential for treatment only. Consider early transfer of deteriorating patients to ICU medically essential transport only. Inform receiving department of COVID-19 patient beforehand. Transporting team should wear PPE. Some recommended all everything. CDC recommends full PPE while handling the patient, but then only wearing a face mask during transport. Patient should wear surgical mask if not intubated. Do not transfer on high-flow nasal cannula, non-invasive ventilation, etc. Cover patient with a clean sheet. Clean and disinfect all high-touch surfaces, including side rails, headboard, footboard, etc. Routes should be designated and dedicated if possible between departments to minimize contact with others. If team must pass through bystander area, it is advised to have security or someone who can safely clear the area prior to arriving. Any accompanying security should wear masks. If intubated, use transport ventilator, if available. If no transport vent available, consider bagging with filters with PEEP valve.